Hello and good morning, Aren. Today we are going to look at cancer treatment. As we all know, cancer is a disease that is normally characterized by disrupted control mechanisms governing cellular survival, proliferation, and differentiation. So these cancer cells are what is commonly referred to as neoplastic cells. And these neoplastic cells normally display abnormal cell surface antigens. They show signs of immaturity, chromosomal abnormalities such as translocation, and even amplified gene sequences. These cells proliferate excessively, forming local tumors like for the benign tumors, right? And these benign tumors can invade and even compress nearby structures. Some of these tumors could be malignant tumors, and these malignant tumors normally proliferate repeatedly and metastasize, spreading out to distant organs. Cancer progression is normally accompanied by metabolic abnormalities leading to illness, and if left untreated, they could potentially cause death. We have 8 treatment strategies in cancer. In cancer, the first one is surgery, and surgery is normally used for both benign and malignant tumors. As for benign tumors like lymphomas, surgery is normally an option if the tumor is now causing symptoms or if it has invaded nearby organs, resulting into different manifestations. For malignant tumors, surgery aims to remove the tumor itself and some of the surrounding healthy tissues just to ensure that all cancer cells have been eliminated. We also have type of surgeries like cryotherapy or hysterectomy in some cases, which can be used to manage different type of tumors. Radiation therapy is the second one, and this one is normally used majorly for malignant tumors. These are tumors that are capable of spreading to distant parts of the body. So radiation therapy can either used alone or in combination with other treatment strategies. Radiation therapy is very effective in shrinking tumors and killing cancer cells that may remain after surgery. We have 2 types of radiations. We have external radiation, where the radiation comes from a machine outside the body to shrink and kill a cancer cell, or internal radiation, where the radiation comes from implants that have been placed inside the body to shrink a tumor. The most common type of radiation being practiced is the brachytherapy, and it's always almost used to treat cancers related to the head, the neck, breast, cervix, prostate, and the eye. The third strategy is immunotherapy, and this one is normally utilized in certain types of cancers just to boost the body's immunity so that it can be able to fight cancer cells. It is typically used for advanced and metastatic cancers. Number 4 is the targeted therapy. Targeted therapy is normally applied for cancers with specific gene mutation. So targeted therapy will target proteins or genes involved in cancer cell growth and survival. Hormonal therapy is used for cancers that are hormone sensitive. They could be estrogen or testosterone, and this could include like the breast, for example, for the estrogen, and the prostate, okay, for the androgens. Hormonal therapy works by blocking these hormones that normally fuel the growth of that particular cancer. Stem cell transplant is the sixth one. This is commonly used for blood-related cancers like leukemia and lymphoma. Remember, these are hematological disorders. Stem cell transplant helps restore healthy stem cells after high-dose chemotherapy or radiation. The second last one is precision medicine, and in precision medicine is normally used when you have genetic information about a cancer and the patient is available. So it involves personalized treatment plans based on the specific genetic mutations and the characteristic of that particular cancer. Chemotherapy is the last strategy and it is the main focus for this presentation. Chemotherapy primarily is used to treat malignant tumors and to destroy the cancer cells or prevent them from growing or dividing. It is often used when cancer cell has spread or it cannot be managed surgically. So when we are using this chemotherapy, we normally say the use of chemotherapeutic agents or antineoplastic medications, right? So this is aka the chemotherapy, okay? Drugs that are generally used to treat cancer by either killing or inhibiting the growth of these cancer cells. So they do target rapidly dividing cells, right? And this is what we know is the main characteristics feature of cancer cells, right? So what is the main characteristic of cancer cells? They are characterized by rapidly dividing, okay? Rapid division of the cells, all right? Unfortunately, chemo is not specific, all right? It's non-specific. That means what? That means it's going to affect both healthy and abnormal cells. So when it affects normally rapidly dividing cells, like the cells of the bone marrow, the cells of the digestive system, of the hair follicles, it normally leads to significant side effects. So remember, no cell is spared in chemotherapy, okay? Both cancer cells and healthy cells are affected. So the most common side effects involve what? We have hair loss when the hair follicles are affected. We have the weak skin, and we have the bone marrow. When the marrow is affected, it causes bone marrow suppression, which can lead to several ailments. And the one that is so priority to us as RNs is aplastic anemia, right? It's the most deadly. All right. So NCLEX mentioned which one is the most dreadful side effect associated with chemotherapy is bone marrow suppression that is likely to lead to aplastic anemia. All right. All right. Remember, when someone has a weak skin, such patients will not be carrying out the rectal temperature, okay, because these mucous membranes are can easily be severed, resulting into bleeding and other unnecessary complications. So bone marrow suppression is the most feared. Remember, when the bone marrow is affected, bone marrow is the primary site for hematopoiesis, right? And this can be found in the hematological lectures. So when you have bone marrow suppression, it affects the three formed elements, right? So what are the three formed elements in blood, guys? All right, very good. White BCs, we have red blood cells, erythrocytes, and we have the platelets, what we refer to them as thrombocytes. All right. So when you have low blood cell count, especially less than 4,000, that's what now we refer to it as what? Leukopenia, right? Leukopenia. And somebody with leukopenia has increased risk for having or contracting an infection, right? Number two is the red blood cells. We have a low red blood cell, and this is going to result into anemia. Patients are going to present with reduced oxygen carrying capacity of the blood, and this leads to the general feeling of fatigue and weakness, which is the sign for the anemia that we know, right? Next is the thrombocytopenia, low platelet count, especially less than 1,000. All right, remember the normal range is between 150 to 400, 450. And if it is less than 50,000, you have to transfuse, guys. So when you have thrombocytopenia, what is the danger? What is the danger, guys? You're going to have increased risk for bleeding. This is because low platelet levels make it difficult for the blood to clot, and this leads to easy bruising, and bleeding. So your patient is going to present with things like nose bleeding, what is epistaxis, and the GI bleeding, and because of this bone marrow suppression, right? Thrombocytopenia to be precise, all right? Okay, so we have several chemotherapeutic agents that are used to treat cancer, and they are classified so based on their mechanism of action, right? Some are cell cycle-specific, others are non-cell cycle-specific. At the end, towards the end of this presentation, I'll be summarizing for you which medications are cell cycle-specific and non-specific, all right? Let's start with the first group, which is the alkylating agents. Alkylating agents are drugs that work by adding an alkali group to the DNA. So when you add an alkyl to the DNA, it leads to cross-linking and strand breakage, preventing cell division and causing cell death. Remember, the nitrogenous bases on the DNA, they normally pair in this manner. We have adenine pairing with the thymine, while the cytosine pairing with guanine, right? And this binding helps form the structure of the DNA. However, when you have an alkylating agent, which is a drug here being given to treat chemotherapy, it will act directly on the DNA, and this will result into cross-linking and causing strand breakdown. Figure out in this case, guys, you have these two. Of course, normally cytosine will will pair with the guanine and other adenine with thymine. But in this case, you can see this abnormal connection where we have guanine and guanine binding, and this is going to lead to DNA strand breakdown, leading to abnormal base pairing, inhibiting cell division, eventually resulting into cell death. And we have several examples of alkylating agents, but first we have to look at the pharmacokinetics of these drugs. Starting with absorption, right? That is the first stage of pharmacokinetics. Remember, you can follow this link to see those 4 steps or stages of pharmacokinetics. Summarize as add me, all right? Okay, guys, so we have the add me, right? Add me, and A stands for absorption, distribution, metabolism, excretion. All right, let's go, guys. Let's start with absorption. So in absorption, we have the oral administration and intravenous administration. So we have some alkylating agents such as cyclophosphamide, melphalan. This one can be administered orally, and they are normally absorbed in the GIT tract. However, the bioavailability can vary due to factors such as food intake and gastrointestinal pH. Intravenous administration, you find most alkylating agents are administered intravenously just to ensure complete and rapid absorption. Intravenous administration also bypasses the gastrointestinal tract, providing more predictable plasma concentration, which is an advantage for this type of route. As for the drug distribution, alkylating agents, they normally vary in their degree of protein binding. For example, you could get cyclophosphamide has a low protein binding, while ifophosphamide has moderate protein binding. Alkylating agents drugs generally distribute widely throughout the body, including into tissues and organs. So we have drugs like camustin, lomustine. These drugs have the ability to cross the blood-brain barrier, and this makes them to be effective in the treatment of brain tumors, right? Alkylating agents typically have a large volume of distribution, and this indicates the extensive tissue binding ability. In metabolism, right, many alkylating agents normally undergo hepatic metabolism. Drugs like cyclophosphamide, ifosfamide are prodrugs. That means what did you say prodrugs are? Yes, So these prodrugs will require activation by the liver enzymes, especially the cytochrome P450 system, to form their active metabolites. So these active metabolites are the ones that will be responsible for the therapeutic effects as well as the toxic side effects of this drug. Take, for instance, cyclophosphamide. Cyclophosphamide is normally metabolized to phosphoramide mustard, which is an active ingredient responsible for therapeutic effects. We also have the acrolein, which is an active metabolite, and this one is the toxic metabolite that is responsible for causing hemorrhagic cystitis associated with most alkylating agent, cyclophosphamide to be precise. All right? Well, the activity of metabolic enzymes can affect efficacy and toxicity of alkylating agents, and I hope this one you need to know because enzyme inducers, for example, can cause the metabolism and reduce the efficacy of a drug, while enzyme inhibitors can decrease the metabolism of a drug, and this one will increase its toxicity. Let's finalize on pharmacokinetics of alkylating agents by looking at the excretion of these alkylating agents. As we know, most alkylating agents and their metabolites are excreted primarily through the kidneys, and renal function now can significantly influence the clearance and the toxicity of these drugs. So these drugs will require an intact kidney, all right? Some alkylating agents like melphalan can also undergo biliary excretion, although this is less common compared to renal excretion. The elimination half-life of alkylating agent varies widely. For example, the cyclophosphamide has a half-life of about 3 to 12 hours, while camustin has a short half-life of 15 to 20 minutes, and this is due to its rapid metabolism. All right. So, what are the clinical implications of alkylating agent based on the pharmacokinetics that we have looked at? We need dose adjustment, which may be necessary for patients who have both liver and kidney impairment due to the toxicity. We also have we also need to carry out regular monitoring of blood counts, liver, kidney function, and also ensure that our patient hydration status are in high terms, all right, so that we can be able to manage the side effects and optimize therapy. Since there is a potential for drug-drug interaction because of the influence of the P450, we need to know which are these common drugs that are enzyme inhibitors and enzyme inducers. We have already said, and we continue to insist, that inducers are going to increase the activity of the CY450 enzymes, and this could lead to increased metabolism of the drugs that will be administered, potentially leading to decreased drug effectiveness. While on the other hand, the enzyme inhibitors are going to decrease the activity of the CY450 enzymes, and this lead to decreased metabolism of drugs, potentially leading to increased drug levels and risk of toxicity. So it's important for us to know which are the inducers and which one are the inhibitors for us to manage our patients more effectively, right? So I think at this time I'll want us to look at some of the examples of alkylating agents, starting with the one that we have really mentioned, the cyclophosphamide. The only problem with this cyclophosphamide is that it can cause hemorrhagic cystitis, and this is because of the acrolein toxic metabolite. So what can you do as a nurse when you're giving out this drug? You ensure adequate hydration and administer a protective agent to prevent hemorrhagic cystitis. Number two, you also need to monitor for hematuria and encourage frequent urination so that you ensure that the patient is under observation. All right. I4-phosphamide is also associated with hemorrhagic cystitis, so that has to be managed almost in the same manner. Melphalan can cause significant bone marrow suppression, and it's normally excreted through biliary. So as a nurse, you have to monitor the CBC frequently. You assess for sign of infection, because we have bone marrow suppression leading to leukopenia. You educate the patients about avoiding infections and reporting any symptoms of low blood counts. Busulfan is another drug, the fourth drug, and this drug can cause pulmonary fibrosis. What is commonly referred to as the busulfan lung. So what are you supposed to do as a nurse? If you have a patient on busulfan, all right, which is an alkylating agent, you have to monitor the respiratory function. You have to educate this patient about reporting any new or worsening cough and shortness of breath or other symptoms. All right. The fifth drug is chloramphenicol. This drug is normally used primarily in treatment of chronic lymphocytic leukemia and certain lymphomas. All right. Camustin, lomustine, these are drugs that can be able to cross the BBB, and therefore they can be used to treat brain tumors. All right, brain tumors for that case. The eighth drug is the thiotempa, and this one is often used in high-dose chemotherapy regimen for hematopoietic stem cell transplantation. The only challenge here is that as a nurse, you have to ensure that you are monitoring for myelosuppression and infection, and ensure proper administration and handling due to potential for skin irritation and mucositis. Right? The ninth drug is damacabazine. All right. This drug can cause severe nausea, so ensure you pre-medicate with antiemetics. We also have the temozolomide, and this is an oral agent that can cross the blood-brain barrier, so it's normally used in treatment of the gliomas. We have the meclorethamine, which is also known as nitrogen mustard, and this is one of the earliest chemotherapeutic agents. You administer carefully to avoid extravasation. Bendamustine has properties of both alkylating and purine analog, right? So you have to monitor CBC, renal, and liver function. Streptococcinine. This is selectively toxic insulin-producing beta cells in the pancreas. So this drug is normally used in treatment of pancreatic cancer. Remember, you have to always monitor the blood glucose level, because this drug can cause both hyperglycemia and hypoglycemia. Mitomycin is the last example of alkylating agent. This drug acts as both alkylating and as a DNA cross-linker. So as a nurse, you have to monitor for bone marrow suppression, renal function, pulmonary toxicity, and educate the patient about the signs of infections and bleeding. All right? So based on the presentation on alkylating agent, what can you say are the general nursing responsibilities? Yes, monitor CBC, ensure hydration, prevent the infections, all right, by instituting the hand hygiene measures, avoiding large crowds and even sick people. Managing the side effects, like for the nausea and vomiting, you pre-medicate the patient with antiemetics. Extravasation precautions, right? You avoid, because this can cause severe tissue damage, and you educate the patients about adhering to the treatment regimen, potential side effects, and the need for follow-up and to ensure compliance. Okay? Okay, guys. Now we can move on to the next group of drugs, and these are antimetabolites, right? They are a class of drugs that interfere with the DNA and RNA synthesis. So they mimic the normal substrate required for nucleic acid synthesis. We have three groups here, subgroups: folic acid antagonists, example methotrexate; purine, an example of mercaptopurine; and pyrimidine antagonists like the fluorouracil. All right, so these drugs, they resemble the substrate. They compete for incorporation into the DNA or RNA, and this disrupts the normal synthesis process, ultimately inhibiting cell division. Right? So we have several examples like methotrexate. We have 5-fluorouracil. We have cytarabine. We have gemcitabine. The clinical implications of giving out these antimetabolites is that these drugs are very selective for rapidly dividing cells, and this makes them a perfect match for treating cancer affecting mostly rapidly dividing cells, which include cancer cells. But also, they can also affect now rapidly dividing cells that we had mentioned in the introduction, and this can lead to severe side effects like myelosuppression, mucositis, gastrointestinal disturbance, right? Cells can also develop resistance to antimetabolites through various mechanisms. Of course, this mechanism, you're going to look at them at the end of this presentation. They include increased drug influx, mutation, amplification of target enzymes, or causing resistance by increased DNA repair, right? So most cases, antimetabolites are often used in combination with other chemotherapeutic agents just to enhance efficacy and reduce the likelihood of resistance development, right? In terms of administration, you find the methotrexate can be given orally, intramuscularly, intravenously, or intrathecal. 5-fluorouracil can be administered intravenously, cytarabine intravenously or subcutaneously, and gemcitabine is administered intravenously. Right? That takes us to the third group, which are the plant alkaloids and natural products. These drugs generally interfere with microtubule function, which is essential for cell division, or inhibit the topoisomerase enzymes, and this prevents DNA replication and transcription. So we have drugs like the vinca alkaloids, the taxanes, epipodophylotoxins, and captothecins, right? So the vinca alkaloids include examples like vincristine and vinblastine, while the taxanes include examples like the paclitaxel and the docetaxel. The third subgroup of the plant alkaloids include the epipodophylotoxins. All right, the epipodophylotoxins include examples like etoposide, all right, and teniposide. All right, examples of plant alkaloids under the fourth category, the captothecins, include irinotecan and topotecan. Right. So, what are the clinical consideration when you're using these plant alkaloids? Number one is a neuropathy. You find that vinca alkaloids and taxane can cause significant peripheral neuropathy, necessitating dose adjustments and discontinuation in severe cases. Myelosuppression, where some common across all the classes, of course, normally lead to increased risk of infection, anemia, bleeding, and regular components. All right. Next, we have the gastrointestinal toxicity, which includes nausea, vomiting, diarrhea, mucositis, where supportive care with antiemetics and hydration is very crucial. Hypersensitivity reaction normally occurs particularly with taxanes and will require pre-medication with corticosteroids and antihistamines. Secondary malignancies, we have long-term use of epipodophylotoxin, which can increase the risk of secondary leukemias, right? Okay, in terms of administration, vinca alkaloids are administered intravenously. Taxanes will be administered intravenously too. Epipodophylotoxins are administered intravenously or orally, while captothecin are generally administered intravenously. The fourth class is anti-tumor metabolites, and these drugs, they exert their effects primarily through intercalation into the DNA and disrupting DNA and RNA synthesis. Some also generate free radicals, and this causes DNA strand breakdown, further inhibiting cancer cell proliferation. We have examples like the doxorubicin, all right, as the first example. We also have daunorubicin, which is another drug. The third one is bleomycin as an example of anti-tumor antibiotics. Mitomycin, which is also the other drug. So generally, when you're dealing with anti-tumor metabolites, we have to monitor several issues in a patient. Like generally these anti-tumor drugs, which are also called anthracyclines, okay, like the doxorubicin and daunorubicin, they are more associated with the risk of cardiotoxicity. So we do regular cardiac monitoring, like using an echo, which is very necessary in that case. Bleomycin can also cause pulmonary fibrosis, and which this can be life-threatening. So pulmonary function tests should be performed before and during the treatment. Many antitumor antibiotics also cause significant myelosuppression, and this could lead to increased risk of infection, bleeding. Regular blood counts are therefore essential. Secondary malignancies, we have long-term use of some anti-tumor antibiotics, which can cause increase in risk of secondary malignancies, such as therapy-related leukemia. Right? Remember, doxorubicin, and daunorubicin are administered intravenously. Bleomycin is administered intravenously, intramuscularly, or subcutaneously, while mitomycin is administered intravenously, right? Okay, let's look at the fourth group of drugs. They are referred to as the topoisomerase inhibitors. These drugs inhibit topoisomerase enzymes. Remember, topoisomerase enzymes are enzymes that are crucial for DNA replication and repair, and this normally leads to DNA strand breakdowns, right? So we have topoisomerase 1 and topoisomerase 2. What's this the difference between the two? For topoisomerase 1 inhibitors, they normally stabilize single-strand breaks created by topoisomerase 1 enzyme, and this prevents DNA relegation and causing DNA damage. While topoisomerase 2 inhibitors, they stabilize double-strand breaks created by topoisomerase 2, and this prevents DNA relegation and leads to accumulation of double-strand break. In terms of examples, we have topoisomerase A inhibitor 1, right? And we have examples like topotecan and irinotecan, right? Topoisomerase 2 inhibitors, also we have examples like etoposide and teniposide, all right? So that takes us to the sixth class, which are hormonal agents. Hormonal agents, they interfere with the hormone production or hormone action, and this will slow down the growth of hormone-dependent tumors, such as the breast and the prostate cancer. All right? So we have subgroups under hormonal agents like the SEMS, which is selective estrogen receptor modulators, where we have a drug like tamoxifen, aromatase inhibitors, anti-androgens, corticosteroids, and many others. So for the selective estrogen receptor modulators, we have drugs like tamoxifen, where they target the estrogen receptors, all right? So tamoxifen is also referred to as the anti-estrogen, right? It competes with estrogen for the binding of estrogen receptors in the breast tissue, and this blocks estrogen proliferative action on the mammary epithelium. In other tissues like bone and liver, it can also act as an estrogen agonist, right? Okay, so this tamoxifen we normally give 20 milligrams per day. This is an oral tablet, right? Oral tablet. Aromatase inhibitors they block the enzyme aromatase, and the aromatase enzyme normally converts androgen to estrogen. So when this is blocked, it will lower estrogen levels and inhibit the growth of estrogen-dependent cancers. So examples we have anastrozole, and the target is aromatase enzyme, right? Anastrozole inhibits aromatase, leading to decreased estrogen production in postmenopausal women. In terms of administration, we normally give 1 gram orally daily for this anastrozole drug, right? Another example of aromatase enzyme is the letrozole, right? Letrozole, right? Which is going to target this aromatase enzyme. So it's an aromatase enzyme inhibitor, right? It inhibits aromatase enzyme, and this will reduce the estrogen levels, all right? We normally administer orally also, and this year we normally give 2.5 2.5 milligrams orally daily. All right. So aromatase inhibitor, another example, we have aminoglutathamide, and this one, the dose, we normally give 250 milligrams orally twice daily, and hydrocortisone about 20 milligrams twice daily. Acute toxicity, this can cause fatigue, mild nausea, while delayed, it can cause skin rash, adrenal insufficiency, and myelosuppression, right? Next group of hormonal agents, we have anti-androgens. And example, we have flutamide and bicalutamide, right? Remember, flutamide is normally targets androgen receptors, while also the same to this bicalutamide. Flutamide, which is commonly used drug, or you commonly interact with flutamide, right? And generally, of course, anti-androgens, they block the action of androgen. Those are the male hormones by simply binding to the androgen receptors. So they prevent growth and survival of androgen-dependent cancer cells. So for the flutamide, it competes with androgen for the binding of the androgen receptors in the prostate cancer cells, and this inhibits their growth. In terms of administration, we normally give oral tablets where we give 250 milligrams 3 times daily, orally, right? Okay. We also have another group under the hormonal agents, the progestins. So we have the megestrol acetate, where the usual dose is normally 50 milligrams orally 4 times a day, right? Next, we have corticosteroids. Corticosteroids are used in cancer treatment because of their anti-inflammatory and immunosuppressive effect, as well as the ability to induce apoptosis in certain types of cancer. So we have the first one is prednisolone, where we give between 20 to 100 milligrams per day orally. That's an adult dose. We are talking of adult dose. Remember, we are talking of adult dose in our presentation. And we have dexamethasone. Dexamethasone, this one is a potent synthetic glucocorticoid with strong anti-inflammatory and immunosuppressive property. It can induce apoptosis in certain cancer cells. Then we have hydrocortisone, which is an adrenocorticoid steroid class. We normally give between 40 to 200 milligrams per day orally, right? We also have another group under the hormonal, which we have gonadotrophin releasing hormone agonist, where we have goserelin acetate and leuprolide as examples in this case. Okay, that takes us to the 7th class of chemotherapeutic, and this is our targeted therapies, right? These drugs, they will target specific molecules involved in cancer growth and survival. We have examples like tyrosine kinases, also proteins and receptors, and that gives us some of the subclasses under these targeted therapies. So we have tyrokinase inhibitors, we have monoclonal antibodies, and the proteasome inhibitors. So starting with the tyrokinase inhibitors, right? We have an example like imatinib, which you normally give between 400 to 600 milligrams daily. And they target the BCR-ABL tyrokinases, right? The mechanism of action is that they specifically inhibit this BCR-ABL tyrokinase, which is a fusion protein, and this will result from the Philadelphia chromosome abnormality in chronic myelogenous leukemia. This imatinib also inhibits other tyrosine kinases such as the c-KIT or the PDGFR, and this blocks the signaling pathways that promote cancer proliferation and survival, right? And we can be able to see. And it's indicated for chronic myelogenous leukemia, gastrointestinal stromal tumors, and others. It's normally given orally, taken once, right? And we have already indicated you give between 400 to 600 milligrams per day, right? Okay, another example is the ilotinib, which you normally give around 150 milligrams daily orally. They target the epidermal growth factor receptors, mechanism of action is that this drug will inhibit the tyrosine kinase activity of the epidermal growth factor receptor, which is often overexpressed or mutated in non-small cell lung cancer, right? And also the pancreatic cancer. So this drug is normally given or indicated for this non-small cell lung cancer and pancreatic cancer, right? So we have oral tablets, and those are the side effects that are associated with this drug, right? The other subgroup under this class of therapies, we have the monoclonal antibodies, where these monoclonal antibodies are designed to target specific antigen on cancer cells, marking them for destruction by the immune system or blocking the signals that promote the cancer cell growth. So we have examples like the trastuzumab, where you give 4 milligrams per kg IV loading dose, and then you give 2 milligrams per kg per week as the maintenance dose. We have the rituximab, which targets the CD20, right? And then we have now the proteasome inhibitors, which is the third subgroup under the therapies, right? And the proteasome inhibitors, they block the action of the proteasome cellular complexes that break down proteins. So inhibition of this proteasome will lead to accumulation of defective proteins, inducing apoptosis in cancer cells. We have examples of these proteasome inhibitors like the bortezomib, right, which targets the 26S proteasome, right? Then we have, that takes us now to the 8th class of chemotherapeutic agents. Here we have immunotherapies. These are drugs that stimulate the body's immune system to recognize and destroy cancer cells. Under immunotherapies, we have two subgroups. We have the checkpoint inhibitors and the CAR cell therapy. So the checkpoint inhibitors are drugs that block proteins made by some types of immune cells, such as T cells and some cancer cells. These proteins can keep immune responses in check and prevent T cells from killing cancer cells. So by blocking these proteins, checkpoint inhibitors allow T cells now to be more effective to attack cancer cells, right? So we have the programmed cell death and the CTLA, right? So examples of these checkpoint inhibitors, we have example like the pembrolizumab, the nivolumab, and ipilimumab, right? Next, we have the CAT, which still under that, and this subgroup has examples like the tisaglykli, and this is a glycoli normally targets the CD19, a protein found on the surface of B cells, including B cell leukemias and lymphomas. So the CAT cells will bind to this CD419 and kill cancer cells. Side effects, we have cytokine release syndrome, which is a severe immune reaction causing fever, nausea, headache, rapid heartbeat, low BP, difficult breathing, and you normally treat this one by giving interleukin-6 inhibitors like the tocilizumab and corticosteroids. Neurotoxicity, where symptoms can range from mild confusion to severe encephalopathy, and is treated by supportive care and corticosteroids. B-cell aplasia, we have, since the CD19 is also present on the normal cells, their depletion can lead to a decrease in immunoglobulins, increasing the risk of infection. So we could do immunoglobulin replacement therapy in this case. Now we have a miscellaneous group, okay, which forms the 9th group of chemotherapeutic agents, right? These drugs have unique mechanisms which are not covered in these other categories. And examples here, we have asparaginase and hydroxyurea. Asparaginase, where you have the dose could be 20,000 IU per square meters daily for IV for around 5 to 10 days. Asparaginase is typically administered via IM, IV, or subcutaneous. It's not administered orally because it's a protein, and if given, it will be degraded in the GIT. The exact volume of distribution for asparaginase is variable, but generally it's limited to the extracellular space due to its large molecular size. Asparaginase is a protein and does not bind significantly to plasma proteins in the same way small molecules drugs normally do. Asparaginase is metabolized via proteolysis, where it is broken down into amino acid by proteolytic enzymes in the body. The half-life of asparaginase drug can vary depending on the formulation used, e.g. derived or pegylated, right? So the pegylated form asparaginase has a longer half-life, which is up to 5 to 7 days, compared to the native asparaginase, which half-life is about 12 to 24 hours. Asparaginase and its metabolites are primarily cleared through the proteolytic degradation and subsequent renal and hepatic secretion. Find that asparaginase normally catalyzes the hydrolysis of asparagine into aspartic acid and ammonia. So many cancer cells, particularly lymphoblasts in acute lymphoblastic leukemia, are unable to synthesize sufficient asparagine due to low levels of asparaginase synthetase. So asparaginase depletes extracellular asparagine, starving the cancer cells of the essential amino acid, leading to inhibition of protein synthesis, cell cycle arrest, and apoptosis. Right? Okay. So this drug is normally used in treatment of acute lymphoblastic leukemia, lymphoblastic and lymphoma, right? And this is the process it is blocking in that case, right? Okay. We have some strategies that can be used to manage some side effects of asparaginase and drug. You find that you have to administer antihistamines and corticosteroids before asparaginase treatment to reduce the risk of allergic reaction. You can use pegylated asparaginase or asparaginase derived from different bacteria sources in cases of hypersensitivity to E. coli derived form. You could do also frequent monitoring of liver function tests, pancreatic enzymes, and glucose levels, right? Just to try and manage the two, right?